Good afternoon, everyone. Thank you for joining us today for what I believe will be a very informative and I think a lively discussion exploring nursing workforce issues. I'm Bill Hoagland, Senior Vice President here at the Bipartisan Policy Center, and have the pleasure of working with our economic and our health team. I think we've all seen the headlines and read the stories of how the pandemic has impacted our healthcare provider community, particularly the nursing profession. But we also know that there were staffing, training, personnel, safety, and salary issues even before the pandemic. And those issues, unfortunately, will continue to plague our healthcare delivery system probably long after the pandemic subsides. We also know that, and I think we will hear more about this today, that the supply and demand of nurses has historically been cyclical. But we also know that during the pandemic, that nursing vacancy rates rose in hospitals and long-term care facilities, either from burnout or just simple fatigue. And this forced some facilities to cut back on services, and hospitals made use of COVID-19 relief funds to fill staffing gaps with travel nurses, which created another set of additional issues. Several factors have been proffered as to accelerating nurse attrition during COVID. We want to explore some of those issues today with our panel of experts led and moderated by a former nurse herself, Sheila Burke. I hope this panel can suggest what federal or state policies could be considered or enacted, not only to address the current situation, but to better prepare us for the future demands being placed upon a system with an aging population. There was one recent action by Congress did address a disturbing finding I find from a recent study at the University of California, San Diego, that found that nurses have a higher rate of suicide than the public. The Dr. Laura Breen Healthcare Providers Protection Act is a bipartisan legislation requiring Health and Human Services to distribute grants to hospitals, medical professional associations, and other healthcare entities to promote mental health and resiliency among healthcare providers. Dr. Lauren Breen, a physician at New York Presbyterian Hospital, took her own life last April under the stress of pandemic, supervising the emergency department there. And that legislation, by the way, awaits the president's signature. We hope that this issue, along with others raised today by the discussion, will inform BPC's ongoing work. We plan to explore possible bipartisan solutions to enhancing and expanding nursing pipeline, to reducing barriers to entry, such as licensing, salaries, and improving retention rates of those nurses already on the job. So on behalf of BPC, I first want to extend my thanks to the Federation of American Hospitals for their support of today's event. This is the first of two events that we will explore nursing workforce trends, the near-term issues, and as I say, equally as important, the longer term. I will now turn this over to my friend, Sheila Burke, who earned her BS in nursing at the University of San Francisco and worked as staff nurse at Berkeley, a fellow of the American Academy of Nursing, and importantly to us here at BPC, a senior advisor, and now the moderator of our panel. Sheila, over to you.
Thank you, Billy. It is a great pleasure to be with all of you today and have the opportunity to engage with this remarkable group of individuals to talk about the challenges facing nursing. We are at an interesting and critical period of time in terms of nursing. We have opportunities, as Billy suggests, both near-term as well as long-term, to think of the challenges that face us. And I can think of no better way to begin our discussion than with Peter Bierhaus. Peter is a friend of longstanding, someone for whom I have enormous respect. He is a nurse, first and foremost. He is a professor. He's a healthcare economist, known for his work on nursing and on physician workforce issues. He currently serves as a professor and director of the Center for Interdisciplinary Health Workforce Studies at Montana State University. We're appreciative of his work there, but also his continued work with the BPC to assist us as we look at these workforce issues long term. He is an expert for a long period of time, having been at Vanderbilt for a period of time, at the Harvard School of Public Health as an assistant to the CEO of the University of Michigan as well, and the 7 teaching hospitals that make up the University of Michigan's program. He served on numerous boards and committees throughout the years, including the National Institutes of Health and Nursing Research, published an enormous number of articles on these issues. I would draw your particular attention to a September-October article in Nursing Economics that Peter has recently published to talk about the shortage and the challenges we face. And then in January of this year, in Health Affairs, another piece. So I'm going to turn it over to Peter to begin our conversation, and then we'll engage with the rest of our terrific panel. Peter, over to you.
Thank you so much, Sheila. It's wonderful to see you, and thank you to BPC for this opportunity. And we're going to get the slides going. And I think that'll do it. So let me just begin. I have a short amount of time, but a lot of information to describe. So I wanted to begin by taking a big picture look at the total employment in healthcare just before the pandemic and all the way through February of 2022. Now, this is total employment, not just nurses, but everyone. And as you can see, early in the course of the pandemic, all the major healthcare sectors decreased. The most was physicians' offices, and then outpatient facilities. Hospitals did not decrease as rapidly as others, but has still sort of stayed very steadily below pre-pandemic levels throughout this period of time. Home health care has remained below and only recently come up, but it was outpatient care facilities that in October of 2020 finally broke through and reached its pre-pandemic levels. It was in October of 21 when hospitals popped up and it got back to its, not hospitals, excuse me, physicians' offices in its pre-pandemic levels. But you can see the yellow line at the bottom, which is long-term care nursing homes, never recovered, and right now 15% below employment. So Sheila mentioned a slide or a study that was published in Health Affairs. This was funded by the Robert Wood Johnson Foundation, Johnson & Johnson Foundation, the John A. Hartford Foundation, and United Health Group. That study that was published in Health Affairs looked at the first 15 months of the pandemic. What I want to provide now is an update of new data all the way through January 2022. So we're about 2 months old from where we're at this point. And what we see is that overall, many of the nurse indicators are trending back to pre-pandemic levels. However, we are seeing a decrease in RNs employment of about 1%, more so for LPNs and nursing assistants. Wages adjusted for inflation are up. They're up the most for LPNs and the least for RNs. And while unemployment levels spiked early in the pandemic, for RNs and LPNs, they're back down to pre-pandemic levels, but not so for nursing assistants, particularly those of color, who remain, unemployment levels remain above that of pre-pandemic levels. Wanted to point out that this is a positive forecast of the future supply of RNs. We made and published this forecast back in 2017. A few months ago, we updated these forecasts using data all the way through 2019. And just before the pandemic began, the forecasts are in the orange dots, and it's showing that we should be able to replace the 640,000 RNs who will retire in this decade and add 1 million beyond that. So we'll grow this workforce by 1 million. This assumes entry into the workforce continues as it has over the last 5 years. Now, this forecast is threatened. And if you follow your eyes to the far right of the screen, you'll see, and what I'm showing you here is full-time RNs working on a full-time basis, and it's a nice steady growth all the way back through the 80s. We get up to 2021, and lo and behold, look at this steep drop. Now, if you go back for a second, here's the forecast, the lines going up, the orange lines, and look at what's actually been observed. We're down 1.8%, where we would have forecast 4.4% growth. This is of concern, and it relates to what I want to talk about next. But the big question, is this a temporary reduction? Is it a permanent reduction, and what to do? What to do, I think, is we need to immediately control the messaging about nurses and hospitals so that we can assure this forecast, the positive one, will occur. Too much of the current imagery, in my view, too much of the tweeting, the media coverage, the social messaging, all that is really quite dreadful about nurses, oftentimes by nurses, and it's about hospitals. And these negative effects have potential for decreasing entry into the profession. And I want to make this point by having you go back to the 90s. Some of you will remember this. This was a decade of managed care and hospital restructuring. Hospitals had to win contracts with HMOs, which meant that they had to reduce their costs. They looked at labor. Hospitals employ lots of nurses and a lot of high-paid nurses. So obviously this was an area where there was some reduction in employment of nurses. Nurses reacted quite vigorously with protests and marches across the country, particularly in Washington, D.C. The unintended consequence of several years of this was the negative imagery by the media. And what we saw was a decrease in interest in nursing, enrollments, and graduations. And this slide shows this percentage decrease of college freshmen expressing interest in a nursing career starting in around 1993, 94, and it dropped all the way through 2000. That led to reductions in graduations. Notice in 1995, about 97,000 RNs were graduated. A few years later, in 1999, 30,000 fewer per year, down to 67,000. And way out in 2005, 10 years after this began, we still had not picked up the number of graduations. Now, this led in large part to the development of a national shortage of hospital registered nurses that began back in 1998. By around 2001, the American Hospital Association determined that the shortage involved about 126,000 open vacant positions that weren't filled. This was the last great large national shortage we faced. So we were fortunate. We had a Johnson & Johnson campaign for nursing's future was developed and launched in 2002. This was a national campaign. I won't go through all the details of it, but it involved a lot of promotion and imagery, positive imagery of the nursing profession, and celebrations across the country where we brought hospital executives, physicians, and nurses together for an evening of celebration about the profession. Other activities that were part of this campaign. And here you can see the effects. Almost immediately, we began to see interest in nursing pick up, graduations pick up, and that trend line has continued right on to almost today. So once again, we've got to control these messages that we have seen in 2021, which were often negative compared to the messages in 2020, which were very different and very positive. I think this is a shared responsibility. It's on me, it's on you, it's on our leaders, it's on our professional associations, our educators, and the union, and mostly the media. We've got to grow this workforce to take care of a lot of other longer term issues. Now, the second thing I would suggest is that we reset our relationships in three ways. First, with hospitals and nurses. As we're starting to get past the pandemic and it's more in our rearview mirror and not so much in the car or in front of us, it's probably a good time for nurses and leadership to huddle, to listen to each other, to understand, and even to apologize if we said or did something that today we're not so proud of. Either way, but focus on the positives. What was done that was right? What strengths did we learn? What were the skills and the confidence and the clinical development that we acquired, the leadership? What do we want to take forward? And what were the negatives that we want to leave behind, never to be repeated? I think we'll need to carefully assess whether nurses are willing to change and ready for that change. It may be too early, too weary, or not, but figure out where we're at. Can we change? Are we willing to change? A second area is to reset our relationships with students. Students are in these organizations. They've had a difficult time over COVID with this, but I think it's important to meet with them, convey their importance, ask what was positive about this experience, what we as an organization did right, what are the strengths that they saw among themselves and as future leaders, and what's important from their perspective going forward. What would keep them in the profession, keep them in the workforce, keep them in your organization, re-invite them back in. And finally, I think a relationship reset with patients in the community. I think the public looks at nurses as assuring quality, as in keeping them protected and safe. And I believe it would be important to convey to the public what happened during COVID, the good and the not so good. What did we learn? What were our strengths? What are we going to do going forward to assure that that relationship with our patients and with our community is built on relationships that keep them safe and protected and assures quality. And by the way, we should remind the community how many lives were saved. How many people are alive today that nurses and others saved in these organizations? How many vaccinations? How many tests? I think I'll end it there, Sheila, and hopefully said a few things that'll get us up and rolling on this conversation.
Thank you, Peter, very much. It's a terrific way to begin our conversation today. I must say that your comments about the public's impressions brings me back to the days of B. Kalish and sort of all the conversations that occurred those many years ago about the image of nursing as something we've all focused on and been concerned about over the years. But this is a terrific way to begin the discussion. As you heard in the opening remarks, the purpose of our event today is really to begin to look at the current shortage crisis, to really look at it in the context of an historical lens to see whether in fact we are in a cycle and how we alter that cycle. We'll talk about nursing trends and workforce trends. We'll talk about why nurses are leaving the profession and choosing to do other things in addition to sort of simple retirements that we often see. And again, possible solutions. Really what we want to focus on is what are the solutions to this and ways to enhance the nursing pipeline and to really begin to transform those retention rates. And we'll do it from the perspective of people that are involved in clinical care, that are involved in essentially the preparation of nurses in terms of our programs of nursing across the country, and from folks that have to worry about institutions and the really supply and how that affects the kind of services we provide. We're hopefully going to touch on all those issues in the course of our panel discussion and really shine a light on the scope and the scale of some of those problems, and really provide some greater insights into the reasons some of these issues have occurred and what some of the solutions will be. I'm going to begin by introducing our panelists, but I want to be sure and tell the audience that we, in fact, are interested in your questions as well. This is meant as a conversation rather than just a straight Q&A. So please submit your questions through the chat box, the instructions of which were provided to you. And we'll get to as many of those questions as we possibly can by the end of our conversation today. So let me begin by introducing our panel. Dr. Maureen Chadwick is currently the Senior Vice President for Nursing and Clinical Operations at Ascension, which is a Catholic healthcare organization dedicated really to the delivery of services. It is a mission-driven organization and worries about communities across the country. She came to that job having been the Chief Nursing Officer for Ascension, Michigan, where she basically led the implementation of the Nursing Center of Excellence strategy, which is at the heart of Ascension's efforts. She's also a former teacher of nursing research and data management at Penn State. And so she's looked at it from the education standpoint as well as from the practice standpoint. She's published in a variety of journals. Chip Kahn, Charles Kahn, someone who we've all known for a long period of time, is the president and CEO of the Federation of American Hospitals. Chip has a long, long history of struggling with some of the toughest healthcare issues that this country has faced, both on the Hill in terms of his role as the staff director of Minority Health Council for the Health Subcommittee of the House Ways and Means Committee, playing a crucial role during some of the great debates in the 80s and 90s and 2000s in terms of healthcare. Also spent time essentially at the Association of American Health Insurance Plans, HIA, and then moved to the Federation. So it has a perspective from a payer and a delivery system. And again, having struggled with these issues from a policy perspective, helps us think about how we think about it and how Congress could potentially get involved and help solve some of these problems, but is confronting this issue from the standpoint of a provider in terms of overseeing those institutions. And then finally, Dr. Deborah Trotman, who is the president and CEO of the American Association of Colleges of Nursing. And so Deb will be able to talk with us about how nursing schools are struggling with these issues, how they're thinking about how we prepare nurses today as compared to years past, how we in fact are trying to build that pipeline and what some of the barriers are to building that pipeline, and some of the emergency issues that we're confronting in terms of the challenges COVID has presented to us and presented to schools as they've tried to expose students, and also some of the issues with that new graduating nurse and how we essentially assist in transition from nursing school to clinical settings, and what some of those barriers are as well and how we need to address those. So we're going to open it up for a conversation, and I'm going to begin by asking Chip, sort of representing the provider side, if he might at the moment, help us think about essentially what the hospitals have had to deal with in terms of the nursing shortage, and during the pandemic, what the solutions have been and how they've begun to address it. And each of my panelists have been encouraged to talk with one another as well. So I encourage the rest of the panel to respond as well to Chip's comments. Chip?
Thank you, Sheila, and really appreciate the opportunity to be here today, and particularly appreciate Peter's comments. As Peter said, we were sort of heading into some challenges regarding maintaining our level of nursing, and all of a sudden the pandemic happened. And I think the pressures of COVID-19 have really taken us from frontline heroes in nursing and among physicians and for other hospital employees and caregivers to a point now in which we really have COVID and hero fatigue. And that's played out, particularly in nursing, to present a particular challenge. For years, hospitals have done a great job at sustaining teams, at assuring quality and safety through changing practices over the last 2 decades. And a lot of that has been, I think, in a sense, threatened by this overwhelming effect of COVID. We now have nurses cycling in and out at much higher levels because of the effect of COVID. We have nurses retiring. We have younger nurses who have chosen to leave the profession. And we have been able to sustain the care, but the management challenge is there. And I think from a public policy standpoint, it's all of our responsibilities to make sure that in terms of the front line at hospitals, we figure ways to both support our current nurses and also deal with that image issue of frontline nursing that I think has been threatened a bit by COVID, as Peter outlined.
Chip, thank you. It draws me to ask Mo, and Deb has, I'm sure, a sense of this as well, and that is the extraordinary decline in mental health and the sort of noted issues and challenges that nurses are facing on the front line. Chip, as you point out, enormous pressures for anyone who's been involved in the clinical facility over the last couple of years. Mo, I wonder if you could observe, based on your exposure to these issues at Ascension, steep declines in mental health, people feeling really unsupported by their facilities, by industry at large, and what in fact, what kind of systems have been put in place, what kind of steps can be taken, and how we begin to address that question, which has certainly contributed to the number of people retiring early and those who simply have left the profession.
Thank you, Sheila, and all the comments that have been said to this point. And I want to thank Bill for bringing up the Dr. Laura Breen bill, because there is not one health system who unfortunately hasn't lost staff, whether it's medical staff or nursing staff, due to the mental toll that this has taken on mental health, the well-being of our clinicians, mental health well-being. So when we look at people walking away, and each successive surge of the pandemic, more and more people have chosen to walk away. Nurses not, and this is supported by the advisory board, nurses not feeling listened to, and also the emotional toll. They can't unsee what they saw during the pandemic, and what support can we put in place during their work, and also outside of work. There have been so many components that have been built to provide. I just want to go back to the basics in terms of providing chaplains that are rounding. We have advanced practice nurses with mental health backgrounds who are just rounding on the staff, that they can identify folks who may be in trouble, offering virtual support, offering support via apps, offering such a menu of support. But the one thing I will tell you, so we have over 60,000 nurses at Ascension, and we did a Elements of Joy. I think, Peter, you are spot on with, we have to focus on the messaging. We did a survey of our nurses, and this was during the Delta surge in the fall. And while people will leave for money, we found the 4 top things that people would stay for. And this was, we had 23,000 nurses respond to this. Was number 1 was value. Am I valued? Does my employer value? I know I'm valuable, so I can walk away for money, but am I valued by my leadership? Secondly, do I have leaders who inspire me? So really focusing on how do we work with our leaders to inspire staff, to be inspirational leaders, not just task oriented. Third is community. Back to your question around mental health, Sheila. You know, do I feel like I am part of this community, or am I just coming in slogging away every day? And lastly, it was processed. Is my leader helping to remove barriers? So hopefully that helps, because I think that and we are setting up so that people's voices can be heard. So we have frontline nurse affinity groups, we have leadership affinity groups, and really reinforcing how are our staff being heard at every level of the organization, not just within their department, because the innovation and the iteration and the things that they have been able, Peter, to your point, what we've been able to do during the pandemic that we need to keep doing going forward. And some of the things that, the mistakes that we made, although when we look at PPE, the challenges when we didn't bring students, when the whole country shut down and we didn't bring students in to experience what that was like with all of us, I think that was a mistake that we all, you know, have subsequently when we opened back up, because when we look at COVID's not going away, and we had such an opportunity to all learn together. But we did the best, we made the best decisions we could at the time, because we just didn't know what we didn't know. So hopefully, Sheila, I've answered your question, and then some probably.
No, it's terrifically important, and it transitions easily, I think, to a question for Deb. The median workforce of nurses, of registered nurses, the age is 52. And we know there are a host of the departures that are retirement-based, people that have simply been in practice for a very long period of time. But how, in fact, can we address the issue that Mo raises, which is the introduction of younger people? I mean, Peter tells us that there is a resurgence of interest in nursing, that we are beginning to see an increase in the number of individuals interested in nursing as a profession. But the programs are facing enormous challenges. And the question is, how do we get those young people back in? And what, in fact, I mean, this is for Chip as well, what a hospital is expecting of those new graduates. I mean, we're confronting the issues that Mo has raised in terms of extraordinary pressure, extraordinary challenges, the fact that people haven't been in clinical settings for a period of time. How are, in fact, the schools beginning to think about this and respond to this sort of long-term pipeline question?
Thanks, Sheila. This is Deb. I'll start out by thanking everybody for the opportunity to be here, the great comments that have been raised thus far. And there's so much I want to say, so I'm going to try to be very succinct and say, first and foremost, the good news is that there continues to be strong interest in the nursing profession, and that did not waver during the pandemic. We went back in preparation, my staff and I, for this talk and looked at growth and enrollment, which our schools of nursing have been very focused on. In the past 20 years, that growth has been significant, wherein it was initially in the 2000s, we were graduating about 22.5 thousand. It's now up to 82.3 thousand. So that's the good news. Even during the pandemic, it didn't drop. The bad news is it's not growth across all programs. And so we need to look at those programs that are not growing and why that's the case. For example, we are seeing a growth in entry baccalaureate. So there's acknowledgement from the students as well as the employer of the importance of higher education. However, the RN to BSN population, which was in the past growing with respect to pursuing baccalaureate degrees, has leveled off. So we need to look at all those factors. But I would also say we need diversity in the profession. Yes, young, but also to continue to support more senior individuals. We have seen when there's economic downturn that many people look to nursing, second career, and that enriches the profession. So we need to think about how we focus on attracting a very diverse workforce of age as well as most certainly color. We've made some great improvements. The pandemic didn't itself create the challenges about wellness and focusing on a health and well-being, but historically the health professions haven't been very good at it. The good news is we're becoming much more intentional, what we need to teach students and what we need to continue to foster throughout one's career. I heard stories during the pandemic of institutions that stood up playrooms, and they weren't for kids. They were playrooms for the staff that weren't able to go home. We have to allow ourselves and take care of ourselves and then look to take care of others. I think Mo's comment, so important. The importance of being valued, of inspiring ourselves. And I don't think, back to Peter's comment, it's not mutually exclusive. We can acknowledge our realities and still have a positive message about the profession. In academia, I celebrate, there was never, I would say, not never, but infrequently did I hear before the pandemic that the academic community could be nimble. We absolutely proved that not to be true. And so we need to think about how do we continue to promote nimbleness, support and stimulate innovation, and then highlight it. What people learned in the pandemic, we have always been trusted. The Gallup poll has collected that data for quite some time. But I believe in the pandemic, especially early on in some of the media portrayals, there was a deeper understanding from the public of all that nursing was doing to help mitigate the challenges we were facing. And nursing students, they were creating apps to help people engage when they couldn't engage. So there's a lot to celebrate, and we should not discount our realities, and we need to, I think, Mo, that was excellent also, we have to be continuously working to knock down the barriers. One of the barriers for nursing is we continue to turn away qualified candidates, and we have got to correct that. And in part, the way we correct that is address the faculty shortage. That's a part of the bad news. We now see an 8% faculty shortage across the country. That's the highest it's been in many years. It's low compared to the numbers of the percentages rather of shortages perhaps of nurses, but it's high. And part of the reason for that is that we are looking for doctorally prepared, and we don't yet have the number of doctorally prepared that we need. Another is there still is a salary differential. And then a third component I would say is that we must continue to integrate academia and practice so that we're coming together with some innovative solutions for how we can address these faculty challenges. Those are some. I could go on, but I know that the whole time isn't mine, so I'll turn it back. Maybe Chip, I think you had said was next.
Yep. Did you want to comment?
Yeah, I think we do need public policy. Apparently the Build Back Better bill is probably not going to happen, but one of its most important components was a major new level of funding for nurse training and for nursing faculty. And I think as we look forward to the healthcare system post-COVID, we can't avoid these issues. And part of it is having a very, very strong pipeline. And we can only have that pipeline if we, I think, put more funding into it. So some kind of congressional action and new policy is really essential. Now, that's not going to solve the day-to-day problem right now, but we can probably manage our way through that. But this longer run problem, as well as sort of changing the nature of the atmospherics around nursing, really requires, I think, a new public policy.
You know, you're absolutely right. There were, in fact, funds contained in Build Back Better. The good news is the omnibus, which is on its way to the president, in fact, does contain additional funds for nursing education, sexual assault nursing examiners program, learning opportunities. I mean, there are some funds, Title VII and Title VIII, they're traditional funding sources for nurse training for faculty and education. Also have additional funds, and of course a particular focus on rural areas that have had particular challenges in terms of staffing issues in institutions. But it raises another interesting question, and that is the movement out of acute care centers. I thought one of Peter's interesting notes was essentially what the occupancy or the activity rates look like among different settings. And one of the questions in the chat was, in fact, the fact that there are nurses moving out of acute care settings in many cases to telehealth, to really a variety of community-based, home-based care as compared to acute care settings. And so one of the questions is, are we preparing people to essentially do that, and how that challenges the issues, Chip, that you're facing in terms of institutional support, the fact that people are choosing to go into different kinds of settings, and query, are we training them? Are we also training and in fact encouraging people to stay in acute care settings as well? And what do we think these changes in delivery are going to do in terms of the supply? Do we have enough for essentially people that choose to go to telehealth or choose to go to a community-based setting and move out of acute care settings when we know the training for folks that are going to practice in acute care settings, practice in ICUs, are really quite demanding. So our sense of whether or not we're meeting those needs, I know, Peter, you've looked at that question as well in terms of the choice people are making in terms of leaving the bedside and essentially doing other kinds of things.
And Sheila, this is Deb. I would say that we have to do all of the above. The acute care setting is going to continue to have a demand for nurses, and we can't rob one part of the system to fix the other. We do and are opening up more clinical learning experience for students, but yet not probably enough in all of the areas. I have a dear colleague who I have great respect for that runs a federally qualified health center, and it took me a while to talk her into opening up to have student experiences there. But we've got to continue, you know, one case at a time, but even on a broader scale. Many of our schools have stood up clinics where it's even interprofessional. That's my dream, when we're able to come together in a much more robust way than we are today as health professions, learning together and not competing, which we're doing right now for some of the very sacred clinical learning experiences. So I would add that our challenge and our opportunity is to do all of the above.
Mo, did you want to comment?
Yeah, I agree. I think the paradigm shift for us as nurse leaders, and particularly in acute care, is that you don't need X number of years of experience. You know, if you've got somebody who really wants to go into peri-op or into the cath lab or into critical care, we have kind of these sacred cows in our head of you need 5 years experience to do X. When the most recent research the advisory board put out is that most nurses will stay in acute care for 2 years. So how do we as acute care leaders say, interview and then say, where do you want to be in 2 years within our system? And we will help you get there. We will help you navigate. I think the other piece, Deb, is those academic practice partnerships are critical. And we need the funding for residencies, Chip, for nurse residency programs, we can really make some strong academic practice partnership. We can lay the foundation so that when the money is made available, it'll make it just that much stronger as we create what that future looks like. And also interdisciplinary. Nurses want to be treated when we listen to what they say. And we've learned that nurse research and medical research levels the playing field in terms of interdisciplinary care and teaming. Teaming is so critical. It was amazing how quickly we were able to do teaming in the pandemic with our medical staff colleagues in the acute care space when we had more patients than we knew what to do. And we want to carry that forward because there were some very powerful shared learnings there.
Sheila?
Peter, go ahead.
Yeah, a couple of comments. We talked about retirement for this has come up, and I mentioned in my talk we have about 640,000 nurses that we expect will retire over this decade. One thing I didn't show you in the slide that decreased numbers in 2021, it was not from the older nurse. These were from younger nurses. So that was the good news on that slide because I expected it would be retirement. Nevertheless, we'll have retirement, but when you look at where the retirement will be expected, it will hit the non-hospital sectors much harder than it will the hospital sector. We still somehow attract younger nurses. Now, it could be that they don't stay in as long in those settings. I don't know that. But we'll be, I think, in better relative shape there, other than hospital administration and leadership. That is an older workforce for retirement. But the retirement issues going forward are going to be in that more so in the non-acute setting. As far as public policy, I have some mixed feelings about this. It feels as if we are just throwing major amounts of dollars in the healthcare workforce without the accountability. So if we're going to do this, then let's make sure our workforce is educated in geriatrics. We have 70-some million people who will need geriatrics. And when you look at the RN workforce and the APRN workforce, the graduate level nurses, we're woefully inadequate in terms of taking care of them. You could say the same thing for primary care, where 80 million people today are estimated to have inadequate access. Think of the mental and behavioral health, which was already seen in crisis compared to before COVID. Some estimates say that's doubled now. And yet we don't have the nurse practitioners and others in mental health. And with maternal mortality, it's going back up. So yes, if we're going to give not just nurses, but other programs dollars, let's be sure that we hold them accountable for producing the workforce that is needed by society and not just going along and, oh, we'll do this and we'll do that. It's what we like to do. It's what we do. And frankly, I really feel this is a moment for educators, particularly, to really get their values aligned with, are we going to educate a workforce needed by society, or are we going to do something else? And it's an important issue because this decade, all of those issues, primary care, mental behavioral health, geriatrics, are all coming at the nursing workforce. Physicians' workforce isn't going to be able to manage that. So we really need to be thoughtful about that in terms of public policy. One last thought I would say is, there's a lot of talk about surveys. There's a survey all the time. Surveys are very volatile at this point in time, and they really can offer misleading information. So I think we really have to be careful about our factual information as we're thinking about policy going forward. I'll stop there.
We've had a number of questions, some of which we've touched on in the course of our comments, but a number of questions have been submitted that touch on many of these issues. One asked whether or not if there are in fact nurses willing to rejoin the workforce who have left for some period of time, but are not interested in the traditional shift model, not interested in sort of traditional acute care shift environment. Is there space for that? Are hospitals rethinking essentially their clinical settings, their clinical relationships, and essentially what they're asking of the nurses that are on staff? and whether or not there are new opportunities within the clinical settings. Mo touched on some of their new efforts within the Ascension system. But again, many leaving the bedside, but interested in staying in clinical care. The question, what options are the hospitals thinking about? How flexible are we to the requests that are being made of individuals today in terms of going into that clinical setting? And then attached to that, and I'll turn it over to the panel, how can digital technologies assist nurses in sort of meeting some of the challenges of understaffing and burnout? Do we have new tools available to us? Are they in fact being put into place in our hospitals across the country? Certainly telehealth is with outreach, but other thoughts in terms of the ability to monitor people at a distance and whether we're beginning to address some of those opportunities by the way we establish essentially those relationships and that work experience in a clinical setting. But Chip, your sense of whether hospitals are becoming more flexible?
I think we have to divide the issue time-wise. I think right now we are in a situation that is extremely challenging. So hospitals are being flexible because they have a frontline issue. All these the other care issues, which are midterm or longer term, we need to deal with. And actually, when we talk about pipeline, that's longer term. And clearly the issues of nurses in other settings that Peter's raising have to be dealt with. But I sort of have tunnel vision right now, because literally when I ask the CEOs of our organizations, what keeps them up at night, the primary thing is making sure they can maintain their patient care service at the level of quality and commitment they want to make sure there are enough nurses physically there. So I think, and this is because partly of this burnout that took place from COVID. I think the other issue over time is in terms of the front line, and frankly, all nursing, is the advent of all these digital possibilities and the digital record and all the measurement that it offers the possibility of is great. But I don't think we've quite figured out how to make all of this technology user-friendly from the standpoint of the frontline people. And in some ways, I wonder sometime whether we've got more burden and more typing, because now there are just more ways to keep track of things, which is great. But I don't think we've thought our way through how we make it more human.
Chip, you bring up, I'm sorry, Sheila,
go ahead. No, Mo, go, please, go ahead.
You bring up a great point about the cognitive burden of the we are assessing clicks in terms of EHR, but I want to speak to virtual nursing. And one of the things that we're leveraging, Sheila, to the question that was submitted, we are seeing nurses who want to come back in, who will be, let's say you're a 16-year critical care nurse and you want to come back in a virtual nurse role to support the new grad who's working night shift. So they hit the button on the wall because they want a curbside consult, if you will, and they don't have to call a rapid response and they don't need to call a physician. They're just not 100% sure. And to have someone kind of beam in, if you will, and be able to real time provide that support has been really, really powerful when you want to talk about supporting our newest novice nurses. And then also bringing nurses, attracting nurses back in who say, you know what, I had to walk away, but I don't want to walk away permanently. Then the other piece I'll speak to, when I was the Michigan Market CNO, we had a e-sitter hub, I will say, before pre-pandemic. And so it was a hub up in St. Clair, Michigan, up in the thumb, watching 200 beds. By the time I left, it was 250 beds. And what was really powerful pre-pandemic, people valued it. During the pandemic, oh my gosh, did clinicians value that, because somebody had eyes on those patients and was able to either call them or alarm them immediately. So I definitely think, because the sitter population, as we all know, have many, many options outside healthcare now. We were competing with the Amazons and the Costcos of the world, and they wanted our staff because they knew PPE and all of the respiratory precautions. So I do believe It's going to be bumpy, but we will get there and continue to pull that technology into the workspace.
And Sheila, this is Deb. I'd like to comment a little bit on what Chip, Peter, and Mo have said. First, I think, it's not one or the other. We still need federal dollars. We still need policy, and we still need that kind of support. And as Peter said, we have to be accountable, and at all levels, at an organizational level, at a state and at a federal level. And we need to do a better job of showing when we are making these investments, what outcomes they are producing. Sometimes we just get success and then move on. I feel very strongly that we have to drive innovation. And I want to come to Chip's comment first. First, we have to address the oxygen in the room, and there's not enough of it. So we've got to take care of the acute crisis that we're facing, no doubt. But that doesn't mean, though, that we shouldn't have our eyes on the horizon and what are those kinds of things we can do. We need innovation in education as much as we need it in the evolving delivery and practice models. And in nursing, as Mo said, the stronger the integration is with academia and practice, we see that we're standing up those models across the country. We're learning from them. It's not a one size fits all. So I think that is so important. And then competency-based education, we are making strong and significant strides. So moving to competency-based education, that is how we're going to address, are we providing the competence in the graduates that our employers need? And again, by us working together, I think it's going to strengthen what we've been able to do in the past. My last comment, I want to come to something Mo said, and that is so true about, when we think about what gets in our way. There was a book, The Future of Health Professions, many people may have read it, and a quote in the foreword by a British economist said, the challenge of the future isn't so much the generation of new ideas, but escaping the old ones. We've got to challenge ourselves which ones we let go of. Yes, you don't have to work X number of years before you can practice in a certain setting, but we have to strengthen then competency-based education. And then the competencies that the graduates have will be of greater confidence the employers will have in them.
I think one of the startling slides, or one of the pieces of information in Peter's slides that was startling, was the extraordinary decline in the number of individuals serving in long-term care facilities. Mm-hmm. And of course, geriatrics, the aging of the population, the fact that people are in fact getting out of acute care settings, going into either hospital, sort of long-term care facilities or other settings. One wonders, in fact, how that issue gets addressed. And the challenges that Chip identifies for acute care hospitals are really multiplied in terms of long-term care facilities. And whether we're training people for that area, I mean, one of the issues at some point I'd like to come back to, probably in another conversation, will be about whether there in fact are residency opportunities, how we are training in fact and educating our nurses, and whether they're giving that opportunity in terms of the same kind of opportunity medical students are given to essentially go into clinical settings. But what do we do about the long-term care piece of this as well? And the workforce needs in that context.
And you're probably aware that John Hartford Foundation and Terry Fulmer has been a strong advocate for increasing opportunities for nursing students. So I think we'll see more of that, especially for long-term care. There's so many factors, of course, to address. It's not just the learning experience. There's still a significant economic difference. Yep. And also not even in the difference in many of the long-term care settings are not employing baccalaureate and higher prepared nurses. Again, many multifactorial, but I absolutely believe it's a growing segment of our population, and to not have qualified healthcare workers in that environment, that we have to fix that.
I also think COVID was just a disrupting factor here that made this area even more difficult to deal with. I mean, in terms of COVID, I mean, one, now to keep enough nurses on the front line, we're sort of sucking them into the traveling nurse agencies, which I would argue is a negative disruptor, filling a need that needs to be there. But whether it's nurses in whatever setting, they can do so well in a limited time, the way that the agencies are behaving now, that it's making it more difficult for the other nurses. And I think there are other aspects in terms of COVID fatigue that particularly have affected long-term care and other kinds of post-acute that we're going to have to figure our way through it. I don't think we have a lot of answers, because the pressure on those nurses and the pressure on the care in long-term care facilities was even in some ways different, but in some ways maybe more numbing than that in acute care hospitals during the pandemic.
Chip, you touched on an issue. Peter, I'll turn to you in just a second. You touched on an issue that in fact we've got a question on as well, Chip, and that is the role of the contract agencies and the role of traveling nurses. And the question that we were asked was whether or not we expect, as the COVID pandemic, at least the acuity of that begins to decline, whether there will be a move back to staff nurses fully employed as compared to filling those vacancies with travel nurses and contract nurses. Salaries hugely different, people being recruited away to move out of a full-time into a contract environment. Do we expect to see that begin to decline again?
I'd like to hear Mo on that one. What she thinks.
I think eventually it will level off. I think it's really about the culture. I think many organizations, I know we've created our own internal travel pool to compete, because the quality, when we talk about the quality and when we talk about the economic value nursing brings to the table, and I think that's what's so important as part of the conversation, because we do know there are quality challenges when you have constantly different nurses in there. So my goal and my ideal, and it's welcoming people back. Again, when people left to travel, I know there was a thought, well, they're never coming back. Well, we need to leave our ego, at the door and be welcoming when people get tired of traveling, and be welcoming when they want, and they're starting to come back. That's what we're seeing. They want to come back. And again, those 4 things I talked about, we know if we can't control for value, inspirational leadership, community, and process, that people will leave for money. That is something that we learned. And I think that's really where we need to focus on listening to our staff and really meeting them where they're at, because sometimes they just want to be heard. They just want to be heard. But I don't think the travel rates will go down to pre-pandemic levels, just in my kind of experience. I think they're going to level off at a certain place, but I don't think the dollar rate will go down. But I do think that we will see this settle down.
Peter,
that's just my thought.
Thank you, Mo. Peter?
Yeah, I wanted to get back to your question about policy, because I think the other conversation could continue and build up. So I wanted to, in terms of long-term care and nursing homes, I think one policy could be raising earnings. It won't solve everything, but it will be a strong signal. And if we're looking for government roles, I hate to sort of say, oh, go to the government and have them spend more, but there's precedent. When Medicare and Medicaid were developed, we gave hospitals their cost and then some, so that they could have the nurses available to take care of the increasing number of older patients. In later years, I think under the ACA, we gave physicians extra dollars if they were working in rural settings or primary care. So if we really care about this setting, I think it would be useful to have immediate substantial wage increases in that sector. And I think you could get a short run, more immediate flow into that area. And then if nursing education programs and other education programs start being held accountable for producing healthcare workers who can take care of older people in these institutions, we could get a stab at it. So I think there are some policies there. One of the things I did want to ask Mo and Chip is, when I hear all this, I kind of put my big view of the nursing workforce. It's 3.4 million is what I mean. And when you look at that, about 2/3 are in hospitals. And of that, a lot of them are in ambulatory in non-areas that they're not ever going to be really connected to COVID. When you whittle it down, my math gets me to around 300,000-ish or so nurses that have experienced COVID head on, either in the critical care units or in the other units. But in our conversation, it feels like we're talking about all these other 3.4 millions of nurses. And so I really am wanting to know, do Mo and do Chip, do they see these issues? Have they rippled out across all the other sectors, out of your institutions, in the communities? Or do we have a much bigger problem, or should we really be more thoughtful and be confined about the real location of those problems? And I don't mean to distract you from the travel nursing, but I do feel we should be thoughtful about what we're talking about.
I'll just say quickly from my view, because I know, and I want to, I think that at least in terms of the four walls of the hospital, that really all parts of the hospital have been affected by COVID at some level. And whether it's the nurses in the ER or even nurses in other areas, they had to change the way they approach things because of COVID. And it had such an impact early on by forcing us to shut down and then come back up, that I think it was a traumatic experience really throughout the institution, at least as far as I've seen. I leave it to Mo.
Yeah, thanks, Chip.
And I'll add, and I know we're getting close to time, but what I will add is it did affect everybody, Peter, and quickly. So when I was in Michigan and it just hit everything, certainly Southeast Michigan, really, really hard. When we had to, we shut down our medical groups and we were moving the staff and ambulatory care into the hospital to help. It was just, there were patients everywhere. When we shut down surgery, we used the ANA from 2008, the adopting standards for care under extreme conditions, the guidance for professionals during pandemics. We used a tiered staffing model. We had deputized staff. We had functional staff. We pulled medical residents in to help staff, but all of the surgery staff, and that's where we saw a huge turnover in surgery staff, because we shut down the ORs, but we didn't lay people off. Some systems laid people off. We moved them all into acute care. So put them in, but again, a lot of education. We were doing a ton of education to get people in a position to be so safe and helping. So maybe an ICU nurse had 3 deputized OR nurses with her to help care for 6 patients, if you will. So I think that's where people can't unsee what they saw, if that makes sense.
Yeah, that helps.
Well, we could go on for an extended period of time, and we will certainly come back to these issues. As Billy mentioned at the outset, this is the first of a series of conversations, but it's been enormously helpful. And I want to thank our panel for really sharing their thoughts, their experience, their knowledge, and encourage all of you who participated and submitted some terrific questions to follow us. We will continue this conversation. But again, let me, on behalf of BPC, thank the entire panel and thank all of you who participated. Well done.
Thank you, Sheila.
Honored to be here.
Thank you.